Hi everybody, this is Dr. Chitra and this is my humble attempt to all of you, those who are appearing for the MRCOG Part 2 exam and hope to clear this exam. This is a humble attempt from my side to help you clear this exam. So today in this video, we will be having a quick recap about the NICE guideline on management of diabetes in pregnancy. There are a lot of facts and figures and I could be wrong at some point of time, so please excuse me for that if any of the figures I cannot recollect properly. Basically, you have two types of diabetes in pregnancy: women those who are already diabetic, and women those who develop diabetes in pregnancy, called as gestational diabetes mellitus or GDM. So what about those who are already diabetic? In the preconceptional period, the targets that they should be achieving is they should be having an HbA1c of 48 millimoles per millimole or less than 6.5%. And if the HbA1c is greater than 86 millimole per millimole or more than 10%, strongly advise against a pregnancy because the risks to the fetus are very high. So advise them to go back, optimize their levels and then come back. In the preconceptional period, it's also important that you advise them lifestyle modifications. So anyone with a BMI of more than 27, they should be advised to lose weight. Then in the preconceptional period, if they have not had a visit to the ophthalmologist for a retinal scan and to the nephrologist, please tell them to do so. Anyone having a creatinine level of more than 120 millimoles per liter or albumin creatinine ratio of more than 30 milligram per mole, or those who have like an EGFR of less than 45 ml per minute per 1.73 meter square, please refer them to the nephrologist. Okay, the targets of blood sugar that they should be achieving is a fasting sugar level of between 5 to 7, and during the day it should be between 4 to 7. Now what about gestational diabetes? So these are women those who develop diabetes during pregnancy. Not all women do that, and there are a group of high risk women. So which is the high risk? Anyone who has a booking BMI of more than 30, previous history of GDM, a previous macrosomic baby, that means baby weight of more than 4.5, family history, the first relatives if there is type 1 diabetes, or those who are BAMI, that means black, Asian and minority ethnic. So in the UK, all these women, they are offered a GTT at 24 to 28 weeks of pregnancy, and if found to be GDM, then they are given interventions. Now those who have a history of GDM, they are offered a GTT 75 grams at booking, and if this is normal, then repeat the GTT again at 24 to 28 weeks of pregnancy. How do you diagnose GDM? So anyone who has a fasting glucose level of 5.6 or above, or 2 hours post glucose of 7.8 or above, they are diagnosed as GDM. Even one abnormal value is diagnosed as GDM. So the magic numbers to remember is 5, 6, 7, 8. Now if they have GDM, you will offer them interventions immediately. So if the fasting is less than 7, no comorbidities, then for 15 days you offer them lifestyle modifications and you check the glucose levels again. So if after 15 days the glucose levels have come back to normal, then they can continue with the lifestyle modifications. If fasting is more than 7, immediately you have to offer them insulin, lifestyle modifications, and if needed, metformin also. What about those who have fasting glucose levels between 6.1 to 6.9 and with some complications like polyhydramnios or macrosomia? For these women, they need to be put on insulin immediately with or without metformin, and of course lifestyle modifications are a must. Okay, so these are the diagnostic criteria. Now coming to the antenatal management of those who have diabetes already. So at the booking visit, you have to check their sugar levels, see what drugs they are on. Some of the drugs contraindicated in pregnancy would be ACE inhibitors or angiotensin receptor blockers. statins, so these have to be stopped either in the preconceptional period, or once the pregnancy test is positive, immediately change them over to some drugs which are safe in pregnancy. Then you will start high dose folic acid for them, and they will be jointly managed with the obstetric team and the diabetic team. Okay. Then if they have not had a retinal scan or a visit to the nephrologist in the prior 3 months, please arrange for a visit for that. And indications for referral to the nephrologist is a serum creatinine of more than 120, or albumin creatinine ratio of greater than 30 milligram per millimole, or the total protein excretion in proteinuria is more than 0.5 gram per day. In pregnancy, do not do an EGFR. Okay. Then the other visits, all the visits will be more frequent. They will be co-managed with the diabetic team. Extra things that you will do for women, those who have diabetes and pregnancy: at 12 weeks you will start low dose aspirin for them. At 16 weeks you will offer them a retinal scan if they are found to have retinopathy at the first visit. At 20 weeks, anomaly scan, especially to look at the heart, the 4-chamber view, outflow tracts and 3-vessel view. From 28 weeks, extra scans to monitor for growth of the baby. Okay. Now, when do you deliver these women, those who are diabetic? So, they have to be delivered between 37 to 38 plus 6 weeks. Either offer them induction of labor, or you can offer them a cesarean section, as is the clinical scenario at that time. VBAC is not a contraindication for women, or diabetes is not a contraindication for a VBAC. Okay. During labor, they can have all sorts of anesthesia or analgesia as they want, and they can have, like, monitoring of the blood glucose level has to be continuous, and you have to manage the blood glucose between 4 to 7. If it is not being managed, you can consider giving a dextrose and insulin infusion to these women. Now, what those who are GDM? So for GDM, if everything is good, the glycemic control is good, they can be delivered around 40 to 40 plus 6, not later than 40 plus 6. Same principles apply, either induction of labor or a cesarean section, as is the clinical scenario. What are the new things in the guideline? So nowadays they say that you can offer insulin pumps to women, those who are taking multiple injections and those who are not able to achieve good glycemic control without significant hypoglycemia. The other numbers that you have to remember: so women, those who are diabetic type 1 or type 2, or those who are GDM, they have to keep the fasting blood glucose levels less than 5.3. 1 hour post meal should be less than 7.8, and 2 hour post meal less than 6.4. How frequently should they be monitoring their blood glucose levels? So women, those who are type 1 diabetes or type 2 diabetes or GDM, those who are taking multiple injections of insulin, they should be monitoring their blood glucose level 4 times in a day. Fasting 1 hour pre-meal, 1 hour, not 1 hour pre-meal, fasting, pre-meal, 1 hour post-meal and bedtime. So 4 times in a day. Those who are GDM, or those who have type 2 diabetes and they are just taking metformin, or they are on diet control, so they should be monitoring it as fasting and 1 hour post meal. Okay, so this is the frequency at which they would be monitoring. Now, what happens in the postpartum period? So women, those who are GDM, you have to tell them that they will immediately stop all the oral hypoglycemic agents or the insulin that they have been taking. Women, those who are diabetic, they should go back to their pre-pregnancy levels, because during breastfeeding they are likely to get hypoglycemia, and if they continue with the same levels of insulin or the hypoglycemic agents, they will have dangerous hypoglycemia. What about feeding of the baby? So these babies, they have to be with the mother, and the mother should initiate breastfeeding as early as possible, preferably between 30 minutes of birth. And the baby should be monitored closely, and the blood glucose of the baby, it should be seen that it does not fall to less than 2 millimoles. Now, what are the indications of transfer of these babies to the NICU? So, any baby that is born preterm, less than 34 weeks, any baby who is not feeling well, who is obviously showing signs of hypoglycemia, any baby who is dehydrated, or anybody who has a cardiac condition, and then anybody who is showing hyperbilirubinemia, they need phototherapy, anybody showing signs of encephalopathy, all these babies have to be shifted to the neonatal, to the NICU. Then in the postpartum period, before these women are left home, you should again check their fasting blood glucose levels for women, those who are GDM. And for those women with GDM whose blood glucose come back to normal in the postpartum period, at 6 to 13 weeks, offer them a fasting blood glucose level. Or if it is not possible to do a fasting blood glucose level, offer them HbA1c after 13 weeks of pregnancy. Do not offer a GTT again after the woman has delivered. Remember, those who have GDM, they are at a very high risk of developing type 2 diabetes. About 50% of these develop type 2 diabetes in the next 5 years. So the fasting glucose levels, if it is less than 6, you can tell them that they are at a low risk of developing type 2 diabetes later on in pregnancy, but they should maintain a healthy lifestyle, and they should continue with their lifestyle modifications. Those between 6 to 6.9, they are at a high risk, so you should refer them to the diabetic clinic. And those who already have a fasting glucose of 7 or more than 7, then they are already diabetic, and refer them to the diabetic clinic for further care. What about the HbA1c levels? So if you at 13 weeks, if you're doing an HbA1c level and it is less than 5.7, you can reassure the woman that she is not diabetic, or her risk of developing type 2 diabetes is less, but nonetheless she should follow a healthy lifestyle, and she should be annually doing a GTT. Then for those whose HbA1c levels are between 5.7 but less, 5.7 to 6.4, they are at a high risk of developing type 2, so they should be on lifestyle modification, and you can refer them to the diabetic clinic also. Those who have HbA1c level of 6.5 or more than 6.5, they are already diabetic, and please refer them to the diabetic clinic for further care. So these were the important points in the guideline. I hope you found this video helpful. Please let me know in the comments box how is the video and what further videos would you like to have from me. So happy learning to all of you, and I hope that this video is really helpful to all of you. Bye bye. Take